Good evening, everyone. At the outset, I would like to thank Endocrine Society and the organizers for this excellent opportunity, and Dr. Uni sir for the warm welcome. And it's indeed a privilege to present or deliver a talk in presence of stalwarts in the field like Dr. Jai Kumar sir and Dr. Uni sir. And I would say that Dr. Jai Kumar sir has already set the stage for me. He has actually simplified all the buts and ifs in the management of thyroid eye disease. So, as Sir said, thyroid eye disease is a rare condition, but we do keep getting these patients, and once in a while, we do get patients who are not responding to glucocorticoids in the way we want them to, or sometimes they relapse immediately after completing the glucocorticoid doses. So, what to do with these patients, whether we go for the conventional immunomodulatory or immunosuppressant drugs that we have been using mainly in the field of rheumatology and transplant medicine, or whether we choose from the newer available group of monoclonal antibodies. I mean, what's the evidence, like how best can we go through the literature and find an answer for ourselves and our patients, so that they feel that they look and feel that they the way they want to. The prevalence of thyrotoxicosis is around 2%. So it's a very common disease, and the Graves' disease is the commonest cause of hyperthyroidism. Majority of these patients present with kind of overwhelming and more dramatic signs and symptoms related to hyperthyroidism, but other systemic manifestations like thyroid eye disease and thyroid dermopathy are also seen in around 30 to 50% of the patients. And among these 30 to 50% of the patients who have thyroid eye disease, almost 20 to 30% may actually have a severe eye disease. So I mean, it's not that rare. And if we look at the prevalence data for the Indians, again, in India, we have got similar prevalence data, though the epidemiological studies, which are very nicely conducted, are scanty in India. The thyroid eye disease is supposed to be milder in Asians, but Indians as a race wouldn't fit into Asians very aptly, like the facial anatomy, the orbital volume, all is like pretty different if we go to the different parts of the country. So in the typical Asian population, like Orientals, Chinese, Koreans, etc., actually the thyroid eye disease is supposed to be much less severe, whereas the dysthyroid optic neuropathy, which results because of the apical crowding and the shallow orbit and the ocular surface disease, is supposed to be more common. So what is the actual profile in Indians compared to the Europeans and other Asian races is something to, it's going to be very interesting to look at if we conduct future studies. One reassuring thing, if we look at the secular trend in the field of thyroid eye disease, is that the prevalence of severe Graves' orbitopathy has been steadily decreasing over last 5 to 6 decades. It has gone down from 57% in 1960 to 37% in 1990. Probably this is because of the early identification, proper treatment of hyperthyroidism, avoiding hypothyroidism, as well as early referral to the specialist in the field. And also maybe it's related to decreased prevalence of smoking, because the trend is different in the countries where the smoking prevalence has gone up. So when we look at the natural course of thyroid eye disease, right from our residency days, we are taught this Rundle curve, which was put forth by Dr. Rundle in the beginning. And what we clearly understand from the graph here is that thyroid eye disease begins with inflammatory phase, which is like also known as active phase. And during this phase, patients present with a lot of signs and symptoms, edema, redness, inflammation, and the phase lasts for 6 to 18 months, and this is followed by more static or fibrotic phase, where the patients go on to develop more severe proptosis, diplopia, lag of thalamus, or exposure keratitis, etc. More severe the acute phase, more are going to be the sequelae during the progressive and the static phase. So the entire philosophy of treating thyroid eye disease is based on this Rundle curve. If we can treat the active phase efficiently, bring down the inflammation very effectively, the sequelae are going to be less. Like thyroid eye disease, when it presents during the active phase, is literally like a house on fire. And if we just ignore it, the damage is going to be tremendous. But however, if like this fire extinguisher who has timely extinguished the fire, the subsequent course is going to be mild, the damage is going to be mild, and the subsequent rehabilitative procedures, if the patient at all requires them, would probably give better outcomes. So all our treatments right now are geared towards treating this active phase more effectively. So are there any treatment strategies in the form of medications which can actually help our patients when they present with more of static or progressive disease? Is something that, I mean, it is something that we need to find out from the ongoing trials of newer agents. So the current management option, as I said, it's there is a treatment. There are a lot of medications that can actually mitigate the inflammatory process during the active phase. So the gold standard or the primary mode of treatment for active thyroid eye disease is glucocorticoids. And then if the patient doesn't respond to glucocorticoids, then we have other options like orbital irradiation or other immunosuppressants like mycophenolate, cyclosporin, azathioprine. We also have monoclonal antibodies which have become recently available to help these patients. But glucocorticoids are the mainstay of treatment because they are most efficacious, they are less expensive, relatively well tolerated by the patients, and there is a lot of evidence about their efficacy. So again, the same thing is reflected in our guidelines as well, 2016 UGOGO guidelines, which recommend use of glucocorticoids IV over oral doses for treating patients with moderate to severe and active thyroid eye disease. Patients with mild disease may also be treated with glucocorticoids if they have a very severe impairment of quality of life because of ocular surface irritation, etc. And the patients who present with sight-threatening disease like dysthyroid optic neuropathy or corneal breakdown, again they'll require higher doses of pulses of glucocorticoids. And if the patient doesn't respond to glucocorticoid, what to do is a major dilemma. So if we look at the glucocorticoids, they are very effective. There's rapid onset of action within the first couple of injections. The patient can perceive the changes. In fact, by the end of 3 doses of IV pulses, there's significant improvement in the clinical activity score. Almost 80% of the patients respond to glucocorticoids. Also, there are potential limitations because we do use very high doses of pulses, and for over pretty longer course. When the cumulative dose exceeds 7 or 8 grams, that may lead to significant hepatotoxicity. Prolonged course of glucocorticoids can exacerbate problems like weight gain, hypertension, diabetes, osteoporosis, and infection. Mortality data suggests that 1 in 200 patients may actually succumb to our treatment, but thyroid eye disease is as such rare. At least I have not seen any mortality in my experience. Dr. Jaikumar sir would be able to tell us more about his experience. The failure rate is to the tune of 20%, and because the duration of active phase is 6 months to 18 months, many of the patients may actually relapse once the glucocorticoids are stopped. So the relapse rates are very high, around 40 to 50%. So this is one of the challenges when we treat these patients with the glucocorticoids. And one more important problem with glucocorticoids is that though they have very effectively reduced the inflammation during the active phase, they have very little effect on the long-term sequelae like proptosis, squint, and sometimes even glucocorticoids may not be able to save the vision when patients present with severe dysthyroid optic neuropathy, and surgery is the only immediate treatment that's available to save the vision of the patients. So if the patient fails on glucocorticoids, obviously orbital radiation and other immunosuppressants are there for our help. Orbital radiation, when used standalone, has got very controversial results. Some of the studies have shown beneficial results, whereas some studies have said that there is no effect on the active inflammation. But when combined with glucocorticoids, orbital radiation does act well. though there are a number of contraindications for that. And patients who go to orbital radiation, the effect is not immediate. The patients may have to wait for several weeks to see the results, and in many patients can later on go on to develop premature cataracts, mild retinal damage, or even optic nerve damage. So the acceptance of orbital radiation in both the physicians as well as the patients is very poor, because the word radiotherapy itself scares our patients a lot. So I'm not going to talk much about orbital radiation because it's known to all of us from long time. What I'm going to talk about is the recent evidence that has become available about the other immunosuppressive medications. So if we look at the UGO guidelines again, which were put forth in 2016, if the patient doesn't respond to glucocorticoids or if there is only partial response, then we are supposed to use orbital radiation, cyclosporine, or rituximab. But all these recommendations are made based on the data that was available prior to 2016. After 2016, there are several well-conducted randomized control trials that have come forward, and I'm going to take you all through the recent most evidence to guide us to help our patients. So the medications which have gone through rigorous trials now are mycophenolate, azathioprine, and cyclosporine. The data is old. So mycophenolate has been studied in the study where it was compared with IV glucocorticoids. So it was studied in a setting of randomized control trial where patients were randomly allocated to receive either glucocorticoids plus mycophenolate or mycophenolate alone. And the primary endpoints were improvement in the global ophthalmic score, which included a lot of parameters related to clinical activity score, lid aperture, proptosis, squint, etc. So if we look at the short-term if we look at the outcome in the arm which received both glucocorticoids as well as mycophenolate, what we see is that significantly higher number of patients actually had better response. They had less chances of relapse. But if we follow these patients subsequently till week 36, the results are comparable between the two arms. There is no statistically significant benefit in the group which received mycophenolate in addition to IV methylprednisolone. If we look at the cyclosporine data, the data is old. It's from 1980s. And this is from this graph in the middle is from a study by Dr. William Veersanga. He's one of the pioneers in the field of thyroid eye disease. And in this particular study, the patients were randomly allocated to receive either cyclosporine or glucocorticoids. And if the patients did not improve to one of these treatments, then they were subsequently treated with combination of both cyclosporine and prednisolone. So if we look at the initial data, prednisolone appears to be way more effective than the cyclosporine alone. So in prednisolone arm, almost 60% or 61% of the patients improved, whereas in cyclosporine arm, the response rate was only 22. So glucocorticoids are way more superior than the cyclosporine. But when the patients who failed to either of the treatment categories, when they were given combination of the two drugs, the patients who earlier did not respond were now responsive to the tune of almost 60%. So the combination treatment is more effective than the standalone treatment. And if we think of using these medications in patients who are poorly responsive to glucocorticoids, I think combination treatment is the way to go. Going forward to azathioprine, then again, it has got limited data. We have got a recent randomized control trial which became available in 2018, which is 2x2 factorial design study where azathioprine and oral radiotherapy and orbital radiotherapy were used in addition to glucocorticoid treatment, oral glucocorticoids. So there were patients who received only oral glucocorticoids. A second category received glucocorticoids plus azathioprine. Third category received glucocorticoids plus orbital radiation, and the fourth category received both. So if we compare the outcomes of patients who were treated for moderate to severe thyroid eye disease during the active phase, the outcomes at the end of 12 weeks, 16 weeks were not different in the group who received azathioprine compared to the group who did not receive azathioprine. So that's why azathioprine does not feature in any of the recommendations or guidelines at present. So the summary of all these three studies is that combinations work better than the standalone medications, at least in short term, for improving the clinical activity score and for preventing the relapse. But if we look at the delayed response in terms of the various orbital parameters, mostly they are similar between the combination arm versus the glucocorticoid alone arm. These immunomodulatory drugs have hardly any impact on the long-term sequelae like proptosis and diplopia, just like glucocorticoids. And the patients who have received combination therapy, the incidence of adverse effects like drug toxicity, renal toxicity, hepatotoxicity, myelosuppression, diarrheas, lung infections, etc., were significantly higher in the group which received combination therapy. So there is definitely a risk associated with the use of these medications. And before we embark on such treatment regimens, it's important that we rule out at least tuberculosis in our country and the contraindications for these medications. As endocrinologists, we are definitely not well versed with the use of these medications. So it is a good idea to collaborate with your rheumatology colleague or a nephrology colleague who is well versed with the side effect profile and the monitoring of the patients who are on these immunosuppressants. So, if to summarize, the current landscape of management that we have is that during the active phase, we treat most of our patients with glucocorticoids, and if they don't respond, with other immunomodulants. But none of the currently available medications that we are using here in India are not FDA approved. None of them are FDA approved actually, and majority of the patients actually go on to develop sequelae like proptosis, strabismus, poor quality of life. The patients, I mean, the poor quality of life is one of the very disturbing feature, I would say, because the patients, I mean, they want to look the way they looked before. They want to feel the way they looked before, they felt before, and also the ocular surface symptoms. Though we don't consider it in our estimation of clinical activity score, it may be a major driver of poor quality of life in majority of patients. So, and these results from the long-term sequelae because of the exophthalmos and exposure keratitis, exposure conjunctivitis, etc. So, most of our patients would actually require rehabilitative treatment after the active phase subsides. So, what do we do about it? So, and also there are category of patients, as Dr. Jaikumar sir said, that the glucocorticoids may not work, or there may be relapses immediately after tapering the doses or after stopping the glucocorticoids, or glucocorticoids may be contraindicated. So, what do we do? And if such patients are not the candidates for surgery, or if the surgery is not a suitable option for that particular phase of thyroid eye disease, what options do we have? So the answer comes from the understanding of pathophysiology of thyroid eye disease. So earlier, the conventional teaching was that it's primarily TSH receptor antibodies and immune reactivation, immune intolerance, secretion of a variety of cytokines that actually leads to the clinical manifestations of orbital expansion, muscle thickening, fat expansion, and subsequent fibrosis. But now, with the understanding that it's actually the co co-activation of TSH receptor antibodies, as well as co-activation of TSH receptors, as well as IGF-1 receptors, that leads to majority of the changes that happen in the orbit of patients with thyroid eye disease. When these two receptors are co-activated, there is release of several cytokines, and they further recruit the B cells into the orbit, and it's kind of sets self-perpetuating cycle. The orbital fibroblasts actually differentiate to pre-adipocytes which express more TSH receptors, and these pre-adipocytes secrete a variety of cytokines which again perpetuate the process of inflammation, and these pre-adipocytes and adipocytes lead to orbital expansion, pressure on the optic nerve, and also the muscles expand. There is secretion of glycosaminoglycans and hydrophilic hyaluronic acid in the orbit, and this leads to variety of signs that we see in our patients with thyroid eye disease. So, is there that we can do anything about it, target these novel mechanisms of pathogenesis of thyroid eye disease? So the our answer comes from the monoclonal antibodies. So we have off-label biologicals which are available here in India to us, which are rituximab and tocilizumab. Tocilizumab has recently become very popular during the COVID pandemic, and it's kind of used more often by the physicians than the rheumatologists now. So both these are off-label; they are not FDA approved. Rituximab, as we all know, is a monoclonal antibody against CD20. So use of rituximab actually would lead to depletion of the CD20 positive B cells. It would lead eventually to decreased synthesis of antibodies and would suppress the inflammatory process. Whereas tocilizumab is a monoclonal antibody against interleukin 6 receptor. And as we saw in the earlier slides, the cytokines like interleukin 6, rantes, interleukin 16, these are one of the major drivers of perpetuation of inflammation. Blocking this may be helpful in mitigating several processes that lead to exacerbated inflammation in the orbits of these patients. So, what's the data from the clinical studies? So, rituximab, there are several anecdotal reports, small observational reports, case series, which have given a lot of conflicting results. In fact, in some of the case series and the case reports, there was incidence of dysthyroid optic neuropathy. So we really need better, well-conducted RCTs to really judge the benefit of using rituximab in patients with thyroid eye disease. So we have two well-conducted RCTs which are published in the year of 2015 in the Journal of Clinical Endocrinology and Metabolism. So one was by Stan et al. And the other was by Salvi et al. From the Europe. So Stan et al. The studies from USA. In both these studies, the dose of rituximab was almost comparable, and the primary outcome measures were actually improvement in clinical activity score by 2 or more. In a study by Stan et al., where rituximab was compared with the placebo, there wasn't any significant difference in the outcomes between the two arms. So rituximab was as good as giving a placebo to patients with active, moderate to severe thyroid eye disease. Whereas if we look at data from Salvi et al. From Europe, we see very impressive results. By the 16th week of follow-up, we see that patients who had received rituximab had significant improvement in their scores of clinical activity, and this has actually been able to be maintained till the follow-up period of 24 weeks. So how do we actually conclude? What are the take-home messages from these studies? Whether we use rituximab in our patients or we don't use, because after all, it's not an inexpensive medicine, and it is a potentially toxic medicine. Patients can develop serious adverse effect, severe immunosuppression, and flare-up of opportunistic infections. So the data can be analyzed further. Why we got the discrepant results? The answer lies in the baseline characteristics of the patients. So in a study by Salvi et al., majority of the patients were smokers. They were relatively, I think they were relatively younger. The duration of disease was only 4 to 5 months, whereas in study by Stan et al., most of the patients had duration of disease more than 1 year. Also, a majority of patients in Stan et al., where rituximab did not work, had received orbital radiation. So for now, what we can say is that if your patient's profile matches with the clinical profile of patients in study by Salvi et al., you can consider using rituximab. But of course, again, as I said earlier, rituximab is potentially toxic drug, and though the doses that are recommended for treating thyroid eye disease are much lesser and of much shorter duration compared to what is used for treatment of hematological malignancies and rejections, etc., the side effects are less, but nevertheless, there are side effects. So if it is the doses are given multiple times, the patients may have to be covered or given prophylaxis for PCP pneumonia and other viral illnesses. So, going further, what sort of data do we have for tocilizumab? So, tocilizumab was again studied in a randomized controlled trial in Spain. It was a multicentric study across 10 centers. Almost 32 patients were recruited. The patients had moderate to severe thyroid eye disease, which was active at the time of enrollment in the study, and all these patients had actually failed on glucocorticoid treatment. And the tocilizumab was given at 4 weekly intervals for the 4 doses, and the patients were assessed at week 16 and week 40 for improvement in their clinical activity score. And if we look at the primary outcome data, we see that a significantly higher proportion of the patients who received tocilizumab responded compared to the group which received placebo. So tocilizumab is effective, but if the patients were followed up subsequently till week 40, there wasn't any significant difference between the two groups, though the numbers look better. At least 30% of the patients, even at the week 40, are being benefited by using tocilizumab. Again, tocilizumab is a potentially immunosuppressive agent, and the side effects are not unknown. We have seen it in COVID pandemics, patients where it is used, and the patients land up with gram-negative sepsis, fungal infections, opportunistic infections, etc. So similarly, in this study, almost 60% of the patients in the tocilizumab group experienced adverse effects compared to 24% in the placebo group. Of all the infections, 80% of the infections happened in tocilizumab. One patient had severe pyelonephritis. Many patients developed headaches, cytopenias, hypercholesterolemia. And if we look at again at the week 40 data, there is no improvement in the proptosis or diplopia, and the clinical activity score was statistically comparable between the two arms. So do we use tocilizumab or not? The answer is not clear, but because in India we don't have many choices, maybe it is one of the potential agents to be considered for treatment of thyroid eye disease. So far, the paradigm of treatment of thyroid eye disease has been such that the patients receive immunosuppressive agents during the active phase, but this has minimum effect on the long-term sequelae. So patients still develop, significant proportion of the patients still develop proptosis, diplopia, poor quality of life. And so can we do better? These are the pictures of the patients who have received glucocorticoids. This is after at least 6 months to 1 year of follow-up. And as you can see, majority of them have, almost 3 of them have proptosis. They have some amount of exposure keratitis, significant ocular surface symptoms, strabismus, squint, everything. So can we do better? Can we alter this long-term sequelae? So the answer comes from a very novel agent, which is now FDA approved, though it is not still available in India. It's teprotumumab. It's a monoclonal antibody directed against IGF-1 receptor, because we have now understood that IGF-1 receptor and TSH receptor activation goes hand in hand, and majority of the pathophysiological changes that happen subsequently in the orbit are because of the co-signaling or the crosstalk between these two um, pathways. So the mechanism of action of teprotumumab is that it inhibits the cytokine cascade, it prevents the muscle and the adipocyte expansion, and it stops deposition of the glycosaminoglycans in the orbit. So there's a lot of ray of hope to prevent the long-term sequelae of thyroid eye disease. So teprotumumab has gone through phase 2 and phase 3 trials. Phase 3 trial was published in January 2020 in New England Journal of Medicine. It has been studied in almost 176 patients so far in RCT setup, and in this particular phase 3 trial, almost 127 patients with thyroid eye disease were randomized to receive either teprotumumab or placebo. And then the primary outcome data was not just reduction in the parameters of inflammation, but also reduction in the proptosis, which is unlike majority of the trials which are conducted earlier. So the data from the teprotumumab optic study is that the proptosis decreases significantly. Almost 83% of the patients in the study arm had significant decrease in proptosis compared to the placebo. The change, the degree of change in proptosis is also excellent, I would say. There's decrease in proptosis by at least 3.3 millimeters. This is very, very clinically significant and gratifying. There is decrease in the diplopia in the teprotumumab arm, and also there is significant proportion of the patients actually reached a stage of complete inactivity in the teprotumumab group compared to the placebo. And what we see from all these graphs is that the improvement starts happening right from week 12, and it is sustained even at week 24. And if this is just one picture from the patients who were given placebo and the drug, and the top panel you see that the proptosis and the inflammation has actually worsened, whereas in the middle panel you see that the patient who has received teprotumumab has significant improvement in the proptosis. as well as the inflammation, and that can also be seen in the MRI images, which show that there is significant decrease in the orbital inflammation, decrease in the orbital volume, and as well as the muscle swelling. So all this has translated into better long-term outcomes. But teprotumumab, there are several challenges. It's though it is FDA approved, it is still a novel agent. We don't have the long-term data. It's the most important challenge for us is that it is not available as of now in country, and we don't know when it is going to be available and at what price to our patients. How long to treat them with this medication, what is the efficacy in different stages of thyroid eye disease, what's the effect of long-term inhibition of IGF-1 receptor suppression, what are the mechanisms of actions of ADRs and the safety in childhood and pregnancy. There are several unanswered questions. The major side effects that were seen in these particular RCTs were muscle spasms, alopecia.
Madam, please, time is running out. Please,
Yes,
please.
sir. So I've come to the end. So last slide. So there are several potential therapeutic targets if we study the pathophysiological mechanisms more closely, and the agents which would target each one of them are going to be very exciting for the future treatment of thyroid eye disease. And I come to my last slide, and the concluding remarks are that the co-activation of TSH receptor and IGF-1 receptor is the major pathophysiological driver of inflammation and the sequelae, and the teprotumumab appears to be the most promising therapeutic agent at present. There are several novel mechanisms involved in the development of TED, and we are yet to learn many of these. So with that, I thank for the opportunity and the patient listening, and hand over the dais to Dr. Jaikumar, sir.